Good day. This is Antonia Sepulveda. I am the Clinical Practice Committee Chair of AMP, and today it is my pleasure to introduce our speaker for this webinar, Dr. Marilyn Lee. Dr. Lee is a professor of pathology and laboratory medicine and pediatrics and the director of cancer genomic diagnostics at Children's Hospital of Philadelphia at the University of Pennsylvania. Dr. Lee is the lead author of a multidisciplinary working group representing the Association for Molecular Pathology, the American College of Medical Genetics and Genomics, the College of American Pathology, and the American Society of Clinical Oncology. In this webinar today, she will present the AMP, ASCO, and CAP standards and guidelines of somatic variant interpretation and reporting. Dr. Lee?
Thank you, Antonia. Good afternoon, everyone. In today's webinar, as Antonia introduced, I'm going to discuss AMP, ASCO, CAP standards and guidelines of somatic variant interpretation and reporting. And I'm also going to use this opportunity and to use a couple examples to present to you how in our institution we implement this guideline. This work was initiated in 2014, and when multiple professional organizations meet together in Bethesda and to discuss if we should come up with professional guidelines and for the somatic variant interpretation. The goal of the project is to establish recommendations for standards in the interpretation of somatically acquired sequence variants in cancer. We had set up a very strict timelines to achieve our goal. So in February 2015, a multidisciplinary working group was formed, and the members of this working group include representatives from AMP, from ACMG, from ASCO, and from CAP. The group compiled 2 professional surveys, and one is a technical survey, and the other is a reporting survey. The survey was complete in May 2015, and the group started to do literature survey and review, and the database survey and review, and start to compile and write compile evidence and write manuscript. The draft of the manuscript was finished in June 2016, and then we also hosted a few meetings and present our draft to the members of different institutions and gathering the feedbacks and the modified guidelines and the manuscript. And the manuscript was submitted in August of 2016, and it was published online at the end of 2016 and in printing January 2016. So before I talk about the guidelines, I would like to give the definition of biomarkers, what we would say this variant a biomarker. So if a biomarker, and that can predict sensitivity or resistance or toxicity to a specific therapy, we can call it a biomarker. And it may carry other significance, such as a biomarker may alter the function of the gene, and which can be targeted by approved or investigation drugs. It may serve as an inclusion criteria for clinical trials. It may also influence disease prognosis. It may assist in establishing a diagnosis of a type or subtype of cancer. It may warrant implementing surveillance measures for early cancer detection, and that is the definition for biomarkers. So the working group used a strategy to classify all those biomarkers into different levels of evidence. So we use an evidence-based approach, and the evidence include both clinical evidence and experimental evidence. Based on the strength of the evidence, we categorize them into level A, B, C, D, 4 different levels. For example, and level A evidence will carry strongest clinical significance, and the clinical significance can be divided into therapeutics, diagnosis, or prognosis. Sometimes a biomarker may carry multiple different evidence in different areas. Could be both therapeutics and diagnosis. The strength of evidence is very important because we separate them and based on their strengths to different levels. For example, for therapeutic evidence, level A evidence will include FDA-approved biomarkers and that predict a response or resistance to therapies for a specific type of tumor, or biomarkers that are included in professional guidelines and that predict response or resistance to therapies for specific tumor types. Level B evidence are biomarkers that predict response or resistance to therapies for a specific tumor type based on well-powered studies and with consensus from experts in the field. They are not FDA approved, but they may be in the way to be approved by FDA or to be included in professional guidelines, and those are still very strong evidence. Level C evidence is much weaker, and those include biomarkers that predict response to or resistance to therapies approved by FDA or professional societies for different tumor types. And in other words, that is off-label use of FDA-approved drugs. And level C evidence, and that's what we just talked about, and could also be a biomarker, and that serves as inclusion criteria for clinical trial. Level D evidence is even weaker, and that, for example, preclinical trial in either in vitro or in vivo, and that show plausible therapeutic significance based on their experiments. However, if an experiment result is negative, that does not count as a level D evidence. The same is true for diagnosis and prognosis biomarkers. It's based on strength of the biomarker and the evidence of this biomarker, and we divide them into 4 different levels. Now I'm going to give you a few examples of different level and different types of evidence and of biomarkers. So, for example, level A evidence for therapeutics in non-small cell lung cancer, and some patients may carry fusions in ALK, RET, or ROS genes, and those fusions predict patients sensitive to crizotinib and or sorafenib or alectinib, and those are tyrosine kinase inhibitors. Most of the patients may initially sensitive to those drugs, but if the patient starts to have mutation in ALK gene, and they may start to show resistance to those drugs. So mutation study, if you found those and mutations, that will predict those patients not sensitive to those drugs, but they may be sensitive to a different tyrosine kinase inhibitor. For diagnosis, this here I show a translocation between chromosome 15 and 17, which leads to a fusion of PM-RARA. And this is pretty much diagnostic for promyelocytic leukemia. If you see this mutation fusion, you know this patient had promyelocytic leukemia. And those patients, and this marker can also serve as prognostic marker and therapeutic marker, because the patient will have good prognosis if you treat them appropriately, and the patient is sensitive to all retinal acid therapy. For prognosis, an example is AML, and a lot of AML patients have FLT3 ITD mutation, and this is prognostic significance, and it will indicate the patient has poor prognosis. However, at the time we wrote the guideline, and we don't have a good therapy, and that is approved by FDA and for this mutation yet. But in April 2017, FDA approved addition of the targeted therapy midostaurin and for adult newly diagnosed AML with FLT3 ITD or sustained mutation in kinesin domain. So this marker now carries tier 1 level A therapeutic significance, and that just says how dynamic our field is, and we need always consistently review the variants and review the evidence. And a level B evidence I showed here, a therapeutic evidence. For example, hairy cell leukemia, almost all the patients carry a BRAF V600E mutation, and they are sensitive to the tyrosine inhibitor bemirakimab in almost 100%. And this is based on large clinical trials, phase 2, phase 3 clinical trials, although it's not FDA approved, but it's very strong evidence. For diagnosis, and I want to show you a mutation, and which is KIT D816V mutation, and this serves as a weak, minor diagnostic criteria for systemic mastocytosis. So, for example, a patient who had the major diagnostic criteria is infiltrating of mast cells. So if you have that, and with one minor marker, which KIT 116V, and will serve, and you can make a diagnosis of systemic mastocytosis, and that's an example. But if you only have this marker, you are not going to make a diagnosis. And the prognostic significance, for example, pilocytic astrocytoma, and which is very common in pediatric kids with brain tumor. And if you identify the KIAA 1549 BRAF fusion, and those patients in general have good prognosis, and that has been approved by a multi-institution large cohort study, and that showed in almost 1,000 patients carry this fusion, and they don't progress to more aggressive brain tumors. Level C evidence, an example for therapeutics, and as we know, there are a group of ALL, they show expression profile, looks like pH positive ALL, but they don't carry BCR-ABL fusion. And those patients, some of them may carry fusion involve CRAF2, and those patients, and this carry this fusion, they show activated JAK pathway. And if we use JAK inhibitor, a lot of patients will respond to that. And now there are multiple clinical trials set up and to test JAK inhibitor in patients with such a fusion. And so this specific marker can be used as inclusion criteria for this clinical trial. the example for diagnosis, and it was in probably 2012, 2013, and researchers have found mutations in spliceosome machinery genes, and it's quite common in patients with myeloid malignancies that include MDS, MPN, and AML. These mutations themselves, the mutations involve those genes themselves may not be able to make the diagnosis. Specifically, you can't really make a diagnosis, this is MDS or AML. However, these mutations along with morphology can make clinical diagnosis, and this would be an example for level C diagnostic significance. For prognosis, and I have an example of MDS with ring sideroblast. Those patients carries SF3B1 mutation, and those patients in general have much better prognosis. I want to say SF3B1 mutation can also serve as a diagnostic biomarker, which could be tier 1 biomarker, and that is for patients who with MDS, and they have less than 15% of ring sideroblast, and as long as they have 5% ring sideroblast, if they carry SF3B1 mutation, and that can make a diagnosis, which is new updates in 2016 WHO guidelines for hematological diseases. Level D evidence, and which I mentioned earlier, is much weaker. I'm going to give a few examples. So for therapeutics, and we want to see, and we will use those evidence from the preclinical trial or very early phase 1 clinical trial, and that is only for safety and dosing. And an example here is Nuclein 3A, and this is molecule inhibitor, small molecule inhibitor, and which disrupt the reaction between MDS-M2 and TP53, and that will stabilize the normal TP53 function, and that will restore the cell cycle arrest and apoptosis and lead to tumor cell death. And so this is still in a very, very early stage preclinical trial and some very early stage of phase 1 clinical trial, and that would be a level D evidence. For diagnostic and prognostic, and I would use an example of TP53 mutation and deletion CDKN2A. In some of the diseases, and they might be at a higher level of diagnostic or prognostic significance, but in general, and those mutations are very common in different cancers and both hematological diseases as well as and solid tumors. So based on the different evidence, the working group decided we will categorize and the variants into 4 different tiers. Tier 1 variants would be the variants of strong clinical significance and in therapeutics, prognostics, or diagnostics. So that will include the level A evidence and the level B evidence. Tier 2 variants are the variants of potential clinical significance, and certainly that includes therapeutics, prognostics, and diagnostics. And this category variants include a variant with level C evidence or level D evidence. And I'm going to jump to tier 4 variants. Tier 4 variants are variants, and those are deemed benign or likely benign. And those are the variants observed at a significant allele frequency in the general population or a specific subpopulation. And they are, in general, included in a normal population database. And also, there's no existing published evidence of cancer association. And most of the labs use 1% general population frequency to put the variance in this category. But most of the laboratory, they are first line and 1%, and then they have other criteria and to categorize variance into this tier. And any variance, they are not belong to tier 1, 2, or 4, will fall into variance of unknown significance, that's tier 3. And those are not observed as a significant evidence in the general population, nor reported and to have any tumor association. So basically, we don't have enough evidence to group this group of evidence into other 3 categories. So we call them variants of unknown significance. Now I'm going to show a few examples, and maybe one example in each tier. The first example is variance in EGFR, and it's an exon 19 in-frame deletion identified in a patient with non-small cell lung cancer. So this table, which is in our publication, will give you a good view. And if you go through the categories in the first column, and you can pretty much categorize any variance into different tiers. Although we only use a few databases here, and especially now there are more databases published, and so the database we included here is absolutely not exclusive, and you can add any database, you can add any more evidence here, but this is the theme and how you are going to categorize somatic variance. So in this variance, we said is exon 19 in-frame deletion in the EGFR gene. And are there any FDA-approved therapy? Yes, and there are FDA-approved therapy there. Is that in the professional guideline? Yes, it's in the professional guidelines, and this mutation predicts patient sensitive to anti-EGFR therapy. The mutation type is in-frame, is activating. The variant frequency is mosaic, and whether that doesn't look like potentially is germline, and it's not in the general population database, and it has been reported in somatic variant database, not in germline database. And prediction does not apply. Most of the prediction software only predict variants that missense mutation. And you can also look at the pathways and the domains that affect the gene, and which we know this mutation affects the EGFR signaling pathway and MAP signaling pathway and a few other pathways. There are numerous publications discuss of this variant. So we categorize this variant as tier 1A. So when I say tier 1A, because as actually tier 1 in our institution, we put somatic variants as tier 1A. If with pathogenic germline variant, we say it's tier 1B. So that's why it's a tier 1A. So example of tier 2 variants, I gave JAK2 variant here. This is a fusion between a gene with JAK2. As you can see here, you can identify this fusion by different technology, RT-PCR, next generation sequencing, and whether there is FDA-approved therapy for this specific fusion, no. And there is no professional guidelines which say, and that is therapeutic to any existing drug. Mutation type is a fusion, and we don't have much information in the general population database or mutation database. However, there are numerous publications shows and this fusion and will activate JAK pathway and point out this JAK2 associated fusion and will make this patient pH-like ALL, and the patient may benefit from pH-like from a JAK2 inhibitor therapy. So this will be a typical tier 2 variant. Example of variants of unknown significance, I use a test 2 variant, N1260S. There is no guideline for the therapy and or prognosis or diagnosis, and the mutation type is a missense. It could be a germline as the variant frequency is close to 50%. It has a very, very rare, it's been seen in general population, but the frequency is very low. It's 4 to the 10 to the minus 5. And it has never been reported as a mutation, either germline nor somatic. And the prediction software will give you controversy results. Some says potentially damaging, others say polymorphism. There's not much publication there. So if we look at the evidence we have, and rare in general population, no publication, not in the mutation database, we just called variants of unknown significance. Benign, likely benign variants. Example of KIT M541L mutation. I shouldn't call mutation variant. Again, there is FDA-approved drug for KIT, some of the KIT mutation, but not this specific mutation. So you do need to see the genes as well as see the variant itself. Not there is a drug for a specific gene mutation, and any variant in this gene will be responsive to the drug. So that, and you have to pay attention to the variant itself. So we don't really know what the function of this variant is going to be, and because there is not enough study to show that. And it could be a germline because the variant frequency is 51%. And we see in the general population database, the minor allele frequency can be as high as almost 10%. And so, which is probably likely benign variant based on the population frequency. This variant is also present in cosmic, and I think that's just because it's so frequent in the general population. If a patient who carries this variant and has a cancer, and that will be included in the cosmic database, since that database is not clinically curated. And there are a lot of publications talk about this variant, especially early publications. But if we look at the general population frequency, and I think, and this is a benign variant. So, and this variant is also including some of the early over-the-counter small cancer panels. And if your institution use this panel for clinical diagnosis, make sure you don't call this variant as a mutation. So germline mutation in tumor testing. When we test tumors, any tumor sample will include both tumor cells as well as normal cells. And so we really should consider if a variant is germline, as some of those variants carry therapeutic and preventive significance. If a variant, the variant frequency is close to 50% or close to 100, and you need to think about whether that could be a germline variant, especially after adjust to copy number changes. So copy number changes is very common in cancer, and if you have 3 copies, your variant, and a germline variance may become either from 50% to 30% or to 67%. And so you have to think about the copy number change, potential copy number change in tumor, and also large indels. And those indels may affect your variant allele frequency, even though a germline variant and may only show 30% variant allele frequency, because this indel may affect the capture, or affect, if you use applicant-based sequencing, affect your applicant capture. And also some local sequence characteristics, some of the areas is just very hard to capture, and which will affect your variant allele frequency. And also the gene characteristics, is this gene tumor suppressor or oncogene, or if this gene is have a no association with cancer predisposition syndromes, and such as TP53, P10, and so those are the characteristics and we need to consider. And also patient information, and if the patient has family history of cancer, and if the patient has early onset cancer, if the patient has biallelic mutation and of any gene and in the tumor, or that cancer of no association with cancer-prone syndrome, and for example, Perelman syndrome, and you have a TP53 mutation. So those factors need to be considered, need to be taken into consideration if you are going to suspect any variant that could be germline. So if you do suspect a variant, it's germline, and you confirm that it's germline, the categorization and interpretation of variant should be according to ACMG, AMP standards and guidelines for the interpretation of germline variants, and not this somatic variant interpretation guidelines. This slide, I just want to show you the how fast our field is evolving, and the interpretation of the variants should also change if new evidence support the variant, and the new variants come up to support the, this variant carry a different clinical significance. So this is a child with a brain tumor, and it's a grade 3 brain tumor. When we did this case, that was early 2016, and we identified a lot of mutation in this patient. And you can see there is MSH2 mutation with a variant allele frequency of 90%. There is a TP53 mutation with variant allele frequency of 87%. The reason I highlight them in red is because I suspect that those could be germline. And you can see at the bottom, and the last line is a H3F3A mutation, which is with a variant allele frequency of 24.3%, and that was considered tier 2. All blacks are considered tier 2. And late on of this, in this year, the WHO come up with updated guidelines and for new brain tumors. And in that guideline, and there is a subtype of pediatric tumor, diffuse midline glioma, H3K27M mutant. It's a specific subtype because it carries specific clinical significance and prognosis. So H3F3A mutation now becomes tier 1 mutation, tier 1 variant. And in the meantime, we confirmed both MSH2 and TP53 mutation are germline. And so we recategorized that mutation from tier 2 to tier 1B. Now I'm going to talk about recommendations on reporting. And the working group recommends a tier-based reporting system. And we recommend the variant should be classified into 4-tier system Tier 1 to 3 must be reported in descending order of clinical significance. Suspected germline variants, if they are clinically significant, should be confirmed with a normal tissue along with genetic counseling. If they are confirmed as germline variants, and then an amended report should be issued, and genetic counseling, post-test genetic counseling should be offered. And it is not recommended to include tier 4 variants because they are deemed benign and likely benign. And pertinent negative reports should be reported, negative variants should be reported in a disease-specific manner. For example, and if you see no V600E mutation in a patient with a melanoma or malignant melanoma, and then you suspected malignant melanoma, and you should say a V600E mutation was not observed. Or if you see a patient who are diagnosed with neuroblastoma and you did not see MYC amplification because that carries prognostic significance. So you should say no MYC amplification was observed. The nomenclature of variants we recommend to follow Hugo Gene Nomenclature Committee's recommendation, and that includes gene name, transcript ID, nucleotide change, amino acid change, variant allele frequency. We recommend to report those. Genomics coordinates, exon numbers, protein domain, pathway involved, and will be laboratory director's decision. And most of the people will put those in their report. Clinical significance of the variant should be clearly described in the interpretation, and evidence used for variant classification should be illustrated in the interpretation. Reference and databases used to classify the variants should be appropriately cited. If confirmation of a variant is performed, and methods of confirmation and the results should be explained in the report as well. So in summary, the working group developed a tier-based somatic variant characterization and reporting system. The manuscript was published in January 2017 in JMD. We want to emphasize cancer genomics is a rapidly evolving field. The clinical significance of any variant should be re-evaluated on an ongoing basis because the new evidence may come out on an ongoing basis. The guideline dissemination and education is ongoing, as what I'm doing now, and implementation studies and surveys are being developed to inform future updates and the guidelines. So now I'm going to give you a couple examples and to show how in our institution and we implement this guideline. And the first example I'm going to show you is a tier 2 therapeutic variant. So this is a 12-year-old boy with a high-risk pre-B acute lymphoblastic leukemia. The patient was on a very high risk ALL therapy offered by COG. On day 8, the patient still had 43% of blood, no response. On day 29, the MRD is 40%, apparently, and no response. You can see cytogenetically, this patient had very complicated cytogenetic abnormalities shown here. And there is a chromosome 9 abnormality, and we try to rule out pH positive ALL, which is negative, as you can see here. And you see 2 dots, red is ABL1 and green is BCR. There is no fusion. However, on the microarray, we saw a partial duplication of JAK2, as shown here. This is JAK2 gene, and this is a JAK2, and it's only part of the JAK2 duplicated. Immediately, I suspect that this patient may have a fusion. So our fusion panel identified a JAK2 associated fusion, as shown in this slide. And we confirmed with RT-PCR, and a JAK2 inhibitor, ruxolitinib, was added to this patient therapy and in combination with chemotherapy. And we designed a customized RT-PCR specific for this patient and track this patient transcript, fusion transcript, as the therapy going on. And after a few months therapy, and as you can see, 5 months after therapy, the patient, the fusion transcript was not detectable. And we were able to bring this patient to complete remission, and the patient then went on for CAR-19 therapy and followed by bone marrow therapy. Now the patient is 19 months after bone marrow transplantation and is still doing very well. And the second example I want to show you is a tier 2 diagnostic variant. So this is a 16-year-old female who first presented to her dentist and to have a mass on the right mandible. And then the dentist said, oh, no, this is not, and they thought at the beginning, the family thought it was an abscess, and the dentist found out that's not, and you need to see the oral surgeon. The oral surgeon knocked down 3 teeth and then say, okay, this might be a malignancy, and refer to different hospitals, include CHOP. And we could not make a definitive diagnosis at the time, and this is the image of the mass. And then we did a second biopsy at CHOP, and with FISH, with EWSR gene, we see a split of the signal. So, and the patient, even though it doesn't really meet the diagnosis of even sarcoma, but that's the only evidence we see. So patient was diagnosed as a typical even sarcoma and treated as even sarcoma. And a year later, the tumor recurred, and we studied the recurred tumor. We identified a fusion that's associated with EWSR. That's EWSR CRAB3L3, which is a novel fusion never reported before. So we searched the literature and many literatures, and we know it's a novel fusion, but we found the paralog fusion, EWSR with CRAB3L1 and L2, are reported in sclerosing epithelioid fibrosarcoma, or known as SEF. So we did a few extra immunohistochemistry stain and to see whether this patient is SEF. And you can see one example here on the right side, and this is IHC stain with MUC4, and which is positive. So, and that gives us more confidence this patient and has SEF. So SEF is a very rare disease, and there is no standard care. There is no standard therapy, but for most of the publication, it shows wide resection of the tumor, and which carries better prognosis. The patient in general don't respond very well with chemotherapy. So we did, for this specific patient, what we did is we did a radical resection of the tumor and went on immediately with fibular graft reconstruction, and the patient was doing well. As the last time we followed this patient, the margin is actually free of tumor. So, and this example just showed to us if your diagnosis is not right, and your therapy will not be right. So for precision diagnosis, it's not just to identify a mutation and a targeted therapy. A correct, accurate diagnosis and appropriate stratification of patient risk are also very important part of precision cancer care. So the last couple of slides, I want to give a mock report of what we use at the Children's Hospital of Philadelphia. And I often get people email me, ask for a mock report, how we report the somatic variants. So I just put a mock report here, and to show how we do that, we on the first page we list the specimen we received and the diagnosis and the histology diagnosis, and then we summarize the most important findings in the first page and the significance, and then detail interpretation in a descending order from tier 1 to tier 3, and it's listed, and for physicians, if they want to know more details, all the publications cited and databases cited in the interpretation as well. And the variance is listed in the table in the different categories. For very VCF, for variant of unknown significance, we just list the variance. We don't do any interpretation because we don't really know anything. And we also put in our methodology, test background, and how we categorize different variants, and also the limitations of the test in our report. So with this, I will summarize. We have implemented a tier-based somatic variant categorization and the reporting system based on the AMP, ACMG, ASCO, and the CAP guidelines. This system is well received by our oncologists, pathologists, and geneticists at CHOP. We definitely recognize cancer genomics is a rapidly evolving field. The clinical significance of any variant should be re-evaluated on an ongoing basis. If we follow up a patient later, for example, we have a patient who had FLT3 ITD mutation before, we interpret in the way at the time what the evidence has. When the new evidence comes, and we will, if we don't go back to do addendum to the previous report, but if we follow up this patient, and a lot of time leukemia patient will do a second time or third time, we have to do patient 4 times now, and we will say, and this was identified before, and then there are new evidence, and we reclassified this evidence, this variant in a different category. So with this, I want to acknowledge my excellent colleagues in the working group, and they are listed here, and also AMP staff and who are listed here as well. I also want to acknowledge all the people at CHOP who have done an excellent job in our institution. And in our last survey, and 80% of our variants, what we reported, carries clinical significance. And in the cancer center survey, and they have showed in 40% of the cases we've ran, and the identified biomarker carries therapeutic significance. And they may not be always tier 1, but most of them are tier 2 evidence. Some of them completely changed therapy and changed the outcome of the patient. With this, I want to thank you for your attention, and also if you have any questions. Thank you.
Thank you, Marilyn, for a really excellent and very practical talk. This is Antonia Sepulveda, your host today, and I was wondering if you could answer 2 questions that might be of interest to the audience as well.
Sure.
So one of the questions that I have is if you could clarify a little bit further. for example, for TP53, which is commonly mutated in cancers, in which tier would you classify TP53 mutations, specifically in hematologic and solid tumors?
Yeah, I got a lot of people even email me, and also at the AMP meeting ask about this. This is a very common mutation in different kind of tumors. In general, I would classify TP53 mutation in tier 2, and however, in certain tumors, and it may carry more strong evidence. For example, in an MDS patient who has 5q deletion, and we should test the TP53. If TP53 is positive, that predicts resistance to lenalidomide. So, and it is recommended by WHO updated 2016 updated guideline. And if you see a MDS patient with 5q deletion, you should test TP53 to see if they have a mutation. But at most of the time, I would say TP53 would be level C evidence for diagnosis, and probably level D evidence for therapeutics. So put together, this is going to be a tier 2 variant in most of the situations. There are also, we know TP53 is associated with Perelman syndrome, especially if you are dealing with pediatric solid tumor. We have a lot of cases, actually. I can, count, with my fingers, probably in the teens, and we have patient who carries germline mutation in TP53, and we identified actually through the tumor testing, and we suspect the patient had a germline mutation, recommend the patient to our hereditary cancer program, and then after genetic counseling, ran the germline confirmation and confirmed those patients who carry a germline mutation, actually they are a patient with the Perelman syndrome. And that would be tier 1. And in our system, we call it tier 1A. Tier 1B, I'm sorry. Tier 1B, that's germline mutation. But you have to confirm that before you can call it.
Absolutely, very, very clear. So my other question is more in terms of the future of the updated guidelines that I'm sure sometime down the road will be happening. Have there been any discussions to include other genomic alterations, for example, tumor mutation burden and how to report it in upcoming updates of the guideline?
Yes, so the guidelines cannot be steered because the field is not going to be steered, and even germline mutation interpretation guidelines and needs to be updated as new evidence come out. And the somatic guidelines probably is more dynamic because not only the field is moving so quickly, and you can see for the last year, FDA has approved many more drugs probably compared to last decade. So I think because the field is so dynamic and it moves so quickly, and the working group feel the needs of update the guidelines on a regular basis. And we are, as in my talk, I did mention that we are in the process to compile surveys and to evaluate how this guideline is being implemented, and also to collect members' comments, suggestions, and for our future guidelines. And I'm pretty sure, and like molecular tumor burden is going to be part of it, and we will address that. And also, there are new databases come out, and those will be included. We will never be able to exclusively include everything into our guideline, but we will update the guideline on an ongoing basis, include as much as we could.
Thank you so much. That was very helpful. And now I'll conclude from my end, and we'll ask Kathleen to take over. Thank you very much, Dr. Lee.